Hello, my name is Heather Orgeron, and I am presenting my DNP project, which is titled Implementation of a Wake-Up Stroke of Unknown Onset Protocol in the Emergency Department. Stroke is the fifth leading cause of death in the United States. Approximately every 40 seconds, someone in the U.S. has a stroke, which means approximately 795,000 people have a stroke each year in the U.S. alone. Stroke can affect people of all ages. 25% of strokes occur in individuals under the age of 65, and 10% occur in individuals under the age of 45. Approximately every 4 minutes, someone in the U.S. dies from a stroke. Stroke is a leading cause of long-term disabilities and is responsible for reducing mobility in more than 50% of stroke survivors who are at least 65 years of age. Stroke actually causes disability in approximately 2/3 of their survivors. In the U.S., between 2014 and 2015, the total of stroke-related costs, which includes healthcare services, missed days of work, and stroke-related medications, totaled almost $46 billion. Approximately 87% of all strokes are ischemic in nature. An ischemic stroke is when a blood vessel that delivers blood to the brain is blocked and can no longer deliver that blood to the brain. It is estimated that between 14 and 27% of strokes are wake-up strokes. These patients are usually disqualified from receiving alteplase, which is the only pharmacological treatment method for ischemic strokes. If a stroke is identified and treated quickly, most of the effects of the stroke can be reversed. If someone is having symptoms for a long time, they are less likely to recover from the symptoms. There were three primary objectives for project implementation. The Wake-Up Stroke or Stroke of Unknown Onset Protocol would be created and approved by all necessary committees, including but not limited to the Stroke Committee, the Medical Executive Committee, and the Governing Board by November 30th, 2021. The protocol was approved by hospital administration in September 2021 and by the Stroke Committee on December 15th, 2021. It was determined that the protocol did not need to be approved by the Medical Executive Committee and the Governing Board. Several members of the radiology, ED, and neurology teams had reservations about the implementation of the protocol because the facility only has one MRI. This team met on March 7th, 2022 to discuss the reservations and solutions to the potential issues. The second objective was that the DNP student would educate 100% of the ED staff about the wake-up stroke or stroke of unknown onset protocol through staff meetings, huddles, handouts, and signage by January 31st, 2022. This objective was not met within the proposed timeline because the project had not received IRB approval by both the facility and the school at that time. The project received feedback from the Facilities Health Institutional Review Board, or IRB, on December 2nd, 2021, and from the University of South Alabama IRB on February 25th, 2022. After meeting with the members of the radiology, ED, and neurology teams and discussing their reservations, the student was able to start educating the ED and radiology staff on March 8th, 2022. During a staff meeting on March 16th, 2022, 35 out of 45 ED nurses, or 77.78%, were educated on the wake-up stroke of unknown onset protocol. Also, the ED educator was educated about the protocol so that she was also able to assist in educating the individuals who did not attend the staff meeting. There was also copies of the protocol pasted on the walls and in the break room of the ED for nurses to be able to reference. All of the ED providers were educated by the ED medical director and the student via email communication during the week of March 14th through the 18th, 2022. Any follow-up questions were addressed by the student during the ED provider staff meeting on April 6, 2022. The teleneurology team was notified of the protocol change on March 15th, 2022. They were familiar with the protocol because it has gone live at a few other facilities within the system. The protocol was implemented on March 21st, 2022. Third objective was the initiation of the Wake Up Stroke, Stroke of Unknown Onset protocol. 100% of patients who wake up with a stroke symptoms or who had unknown stroke symptom onset time, but who met all other criteria would be eligible for alteplase, would be scanned with an MRI to help determine when the stroke occurred by May 31st, 2022. 9 patients presented to the ED with a symptom of a wake-up stroke or stroke of unknown onset during this period. 8 of these patients were scanned with an MRI. There was no clear reason as to why the patient was excluded from the wake-up stroke or stroke of unknown onset protocol. The provider was educated on the protocol again when that patient was excluded. The clinical question is, will moving the MRI to the acute stroke period while the patient is in the ED for patients with acute ischemic stroke who wake up with stroke symptoms or who have an unknown symptom onset time increase the alteplase treatment rate when compared to the alteplase treatment rates prior to implementation? The main aim of this project was that the patients determined to have symptom onset time less than or equal to 4.5 hours through the use of MRI and who met all other inclusion criteria for alteplase would be eligible for alteplase. This is a copy of the Wake Up Stroke, Stroke of Unknown Onset protocol that was implemented in the ED of a community hospital that is part of a large academic medical center on March 21st, 2022. This protocol moved the MRI from the previous timeline of within 24 hours to the acute stroke period while the patient is in the ED. The initiation of this protocol increased the number of patients eligible for alteplase by providing the ED providers another tool to evaluate patients who presented with stroke-related symptoms after waking up or with an unknown symptom onset time. Patients were chosen to undergo the MRI during the acute stroke period while the patient is in the ED if they presented with symptoms of a wake-up stroke or stroke of unknown onset. The inclusion criteria included all patients over 18 years of age who presented to the ED with symptoms of a wake-up stroke or stroke of unknown onset, and patients with an acute ischemic stroke. Patients were not excluded based on gender or ethnicity. The only exclusion criteria included any patient under the age of 18, patients who could not undergo or refused an MRI, any patient who presented to the ED with a known stroke onset time, and patients who had a known exclusion to alteplase. All patients presenting to the ED with a wake-up stroke or stroke of unknown onset between the protocol implementation date of March 21st, 2022 and May 31st, 2022 were to be included. Based on the data from 2021, we anticipated between 10 and 15 patients. The facility had a stroke protocol in place for any strokes that occurred within the previous 24 hours. However, if a patient presented with a wake-up stroke or a stroke of unknown onset, the patient was previously determined to be ineligible for alteplase. The project did face a few barriers. As I said prior to this slide, the facility only has one MRI, which can affect the availability of the MRI when a patient with a wake-up stroke or stroke of unknown onset presents to the ED. We had to create a decision tree on who was able to be removed off the table, when could a patient be removed off the table if a wake-up stroke or stroke of unknown onset patient arrived in the ED. Because MRI was not part of the diagnostic imaging used for strokes in the acute phase, a sense of urgency surrounding the MRI was necessary and was not there previous to this implementation. Because treating the wake-up stroke and stroke of unknown onset is a fairly new concept and published literature is limited, a successful protocol was not found in the literature. So we did have to create one ourselves. All of this facilities associated with the large academic medical center that use Epic Hyperspace as their electronic health record use a data collection tool called the acute stroke log to collect data associated with the acute stroke process. The acute stroke log is an Excel spreadsheet that analyzes data from a report generated by Epic Hyperspace. The report collects data such as the patient's name, medical record number, age, gender, ED provider, stroke onset date and time, and any times associated with the diagnostic tests and imaging associated with the acute stroke process. This tool was used during and after the protocol implementation so that data associated with the participants could easily be tracked and trended. A report with stroke-related data was run, and the data was confirmed by the ED Stroke Champion on a weekly basis, which allowed the student to evaluate the protocol success throughout the process. The acute stroke log calculates the average times for several stroke-related metrics, including door-to-needle times, door-to-ED provider times, door-to-MRI times, and door-to-CT times, and any demographics. The acute stroke log also aggregates the data on a monthly basis so that the D&P student could easily trend it. The acute stroke log showed the student how many patients presented to the ED with a wake-up stroke or stroke of unknown onset, and how many of these patients had an MRI during the acute stroke phase. The goal was that all patients who presented to the ED with a wake-up stroke or stroke of unknown onset and who did not have any contraindication for alteplase would undergo an MRI to be considered effective. When the patient went to the MRI, the radiologist was looking for a DWI flare mismatch. DWI is diffusion weighted imaging, and flare is fluid attenuated inversion recovery. If the radiologist was able to see a DWI flare mismatch and all other criteria are met, 100% of the patients would be given alteplase. Between March 21st, 2022 and May 31st, 2022, 40 patients presented to the facility with stroke or stroke-like symptoms. 9 patients presented to the ED with symptoms of a wake-up stroke or stroke of unknown onset. 3 of these patients were male, 6 of these patients were female. 1 of the patients were between 30 and 39 years of age, 4 were between 60 and 69 years of age, and 3 patients were between 70 and 79 years of age, and 1 patient was between the age of 80 and 89. 6 of these patients were Caucasian and 3 of the patients were African American. 8 patients who woke up with stroke-like symptoms or who had unknown symptom onset time were scanned with an MRI to determine the presence of a DWI flare mismatch. There was no documented reason as to why 1 patient was excluded from the protocol. Unfortunately, none of the patients had a DWI flare mismatch and were eligible for alteplase. While none of the patients who woke up with stroke symptoms or who had an unknown symptom onset time and presented to the ED within 4 hours of symptom onset had a DWI flare mismatch, 88.89% of patients who woke up with stroke symptoms or who had symptoms of unknown onset time were scanned with an MRI to determine the presence of a DWI flare mismatch. The initiation of the protocol gave providers a diagnostic tool to determine if a patient was eligible for alteplase, despite waking up with stroke symptoms or not knowing the stroke onset time. Prior to the implementation of this protocol in the ED, the patients who woke up with stroke-like symptoms or who had an unknown onset time were automatically disqualified from treatment options. As a result, this project is considered clinically significant. A two-tailed proportion test for significance produced a test statistic of 4.98, which makes the implementation of the wake-up stroke protocol also statistically significant, with a p-value of less than 0.002. The implementation of a wake-up stroke of unknown onset protocol allowed the facility to implement an evidence-based practice protocol that was shown to improve outcomes for stroke patients, but had not been widely adopted to improve the quality of care for stroke patients. With this implementation, patients are no longer considered automatically excluded from receiving alteplase. If a DWI flare mismatch is identified, patients are considered for treatment with alteplase, which can lead to improved outcomes for the patient. Because the protocol moved the timing of the MRI from the 24 hours of admission into the hospital to the acute stroke period while the patient was in the ED, this project was considered sustainable because there was no financial obligations and no additional testing requirements related to the project implementation. Thank you for listening to my presentation about the implementation of a wake-up stroke, stroke of unknown onset protocol in the ED.